Over 500,000 people are admitted to U.S. hospitals every year for gastrointestinal bleeding. It is the single most common GI diagnosis requiring hospitalization. Look at these two patient profiles. Patient A is on the top, patient B is on the bottom. Patient A has abdominal pain that peaks roughly 30 to 60 minutes after finishing a meal. Because eating triggers the pain, this patient avoids food and has been steadily losing weight. Patient B has the opposite timeline. Eating food actually relieves their pain temporarily. The burning sensation returns 2 to 3 hours later and frequently wakes them up in the middle of the night. Based on that exact timing, we can map the physical location of the damage. Patient A has a gastric ulcer, located in the stomach. Patient B has a duodenal ulcer, located further down in the first part of the small intestine. Normally, the stomach is lined with a thick layer of mucus. This barrier is highly protected and acid-proof, shielding the delicate tissue underneath from harsh digestive fluids. A bacteria known as Helicobacter pylori, or H. pylori, targets the lower part of the stomach called the antrum. It colonizes this specific area because the antrum lacks the cells that secrete acid. Once embedded, H. pylori tricks the host, forcing it to overproduce gastrin. This signals the stomach to pump out massive amounts of acid, overwhelming downstream defenses. The unmitigated acid burns away the tissue layer, creating a deep crater, a peptic ulcer. Bacteria aren't the only cause. Chronic use of non-steroidal anti-inflammatory drugs, or NSAIDs, like standard over-the-counter ibuprofen, chemically strips away that protective mucus layer over time. Whether initiated by a bacterial infection or a daily painkiller, the pathology is identical. The body's highly protected acid vat turns on itself. To confirm the exact location of the damage, doctors perform an upper GI endoscopy. They guide a small, flexible camera down the throat to map the esophagus, the stomach, and the duodenum in real time. If the biopsy detects H. pylori, doctors prescribe triple therapy. This protocol combines 2 specific antibiotics to kill the bacteria, alongside a third medication called a proton pump inhibitor. The proton pump inhibitor, or PPI, chemically blocks the stomach from producing new acid. By neutralizing the internal environment, the damaged tissue can heal naturally over the course of 1 to 2 months. For ulcers caused by NSAIDs, the protocol requires immediate cessation of the painkillers. Patients also need to eliminate lifestyle irritants like alcohol and smoking, which slow down the healing process. For the vast majority of patients, isolating the chemical trigger and dropping the acid levels cures the ulcer completely, long before any physical surgery is required. When an ulcer goes untreated, the damage accelerates rapidly. Patients begin presenting with alarm symptoms, severe dizziness, vomiting blood, and black tarry stools, or melena, which indicates digested blood in the GI tract. The extreme escalation is a giant duodenal perforation. The acid burns entirely through the organ wall, creating a hole larger than 2 centimeters that leaks digested food and bacteria directly into the abdominal cavity. At this exact moment, the condition ceases to be a chemical imbalance. It becomes a catastrophic structural failure that demands emergency intervention. Repairing a perforated organ typically requires open abdominal surgery, but many patients suffering from severe ulcers are elderly or have multiple underlying health conditions. Their bodies simply cannot withstand the trauma of a major operation. For these fragile cases, doctors use an endoscope to deploy a covered duodenal stent. This cylindrical mesh expands inside the intestinal tube, physically plugging the hole from the inside, while an external drain is placed to clear the abdomen. Looking at this clinical data for a patient cohort treated with stents, we see why this approach is used. Notice the advanced age of the patients and high operative risk. Primary stenting effectively reduces mortality for these frail patients. Minimally invasive stents buy vital recovery time. But if the ulcer erodes deep enough to hit a major artery, doctors must open the abdomen and completely re-engineer the local anatomy. The ultimate surgical emergency occurs when a deep ulcer erodes an artery, causing massive internal hemorrhaging. To stop the bleeding, surgeons execute a 3-point ligation. They stitch one suture directly onto the bleeding point and anchor 2 additional sutures on either side. This cuts off collateral blood supply, stopping flow from both directions to prevent rebleeding. When an ulcer destroys too much native tissue, surgeons use the triple tube technique. They place 3 separate surgical tubes into the tract, one to decompress tension, a second for feeding, and a third to drain acid. A peptic ulcer begins as a microscopic bacterial colonization or a reaction to an everyday painkiller. But if those early chemical warning signs are ignored, medical professionals are forced to completely replumb the human digestive tract just to keep the patient alive.